Hello, I'm Dr. Robert Russo, Executive Director of the Connecticut State Medical Society. Welcome to On Call with Connecticut Physicians, the Medical Society's podcast initiative.
I'm Dr. Bob Russo, the Executive Director of the Connecticut State Medical Society. Just a little background. We are an organization of physicians, more than 4,000 in the state of Connecticut. Our mission is advocacy for the physicians and their patients. We're more than 200 years old and have been involved in the legislature as far back as I can remember, which is probably as far back as anyone on the screen can remember. What we'd like to do is get our legislative agenda out there so you can hear where we're coming from on some of the major issues, and then we'll answer the questions as we go. So first up, off the top is our president, Gregory Shangold. Dr. Shangold is an emergency room physician predominantly in the northeast part of the state. He's also the managing partner of one of the largest ER groups in the state. So I'm going to toss it over to Greg, and he'll talk about high deductibles, insurance policies, and surprise billing. Greg?
Thanks, Bob, and good morning, everybody. So just to set the tables, basically a lot of our legislative agenda is anything that helps provide access to high quality and safe care for our patients. So when we talk about a lot of these issues, that's some of the guiding forces there. So just to set some of the definitions, surprise billing is really more of a technical term. It's not any bill that you get from a physician, but it's when a physician is unknowingly not in a network. And there's multiple reasons why physicians are not in networks when you go to a hospital that you think is in network. In Connecticut, actually in 2016, we created a great law that protects patients. And if insurance companies actually followed that law to the intent, we really would solve most of the surprise billing issues. Secondarily, just this December, there was a federal bill that also will cover some surprise billing. This differs very much from the high deductible health plan. Because of the ever increasing high deductible health plans, many people get bills that are because of the construct of their insurance plans. And it really becomes people are surprised that they don't have coverage. And this surprise billing doesn't really, that term is not to be used with high deductibles. High deductible health plans have really interfered with the doctor-patient relationships because physicians have become the de facto bill collector. And these are products created by the insurance industry, but then made the physician to enforce. And so these plans actually cause patients to delay care and sometimes forego necessary care as much as what an insurance company seems is not essential care. 2 years ago, there was a task force we participated, and we really hope to get to implementing some of the recommendations from that task force. So that's pretty much a summary on surprise billing and where we are with high deductible health plans, Bob.
Thank you, Greg. Now we're going to go to Dr. David Emmel. Dr. Emmel is an ophthalmologist in the greater Hartford area, and he's the chair of our legislative committee and quite active in our efforts to advocate for the patients and the physicians. David, you're up.
Thank you, Bob. The subjects I'm going to talk about are telemedicine and the ambulatory surgery center tax. Telemedicine has been around for a little while, but it has been significantly expanded during the COVID-19 pandemic. In fact, in many ways, it's functioned as a kind of a laboratory for us to explore its potential utility and benefits for interacting with patients. The executive orders issued by Governor Lamont have made this possible and have really been a boon to practices where we just simply haven't been able to, in the early stages, see patients live. There are enormous advantages, and what we would like to see is the executive orders continued through legislative action so that not a broad range of technologies can continue to be used. To give you an example, prior to the pandemic, we were not able to use telephonic communication. I'm an ophthalmologist, and a lot of my patients are in their 80s, 90s even, and they don't have either computers at home or facility using online services to interact live. And there were many times that I was able to provide very helpful service to my patients. And this can be time consuming. I mean, it's not like, we're not talking about refilling prescriptions, but really doing real care over the phone. So we would very much like to see telehealth, telemedicine continue, and in ways that facilitate a bona fide patient-physician relationship with their doctor in Connecticut, strengthen the healthcare home, and also be available to our teaching institutions, Yale, Quinnipiac, and UConn, to use for very valuable consultative services that they provide. The surgery center tax, it was instituted in 2015 and is a 6% gross receipts tax. That means that all income that comes into a surgery center is taxed at 6%. And that includes durable goods such as implants that are used in orthopedic surgery, eye surgery like I do, even though that doesn't represent in any way, shape, or form profits to the ambulatory surgery centers. These centers have been proven to be extremely convenient, safe, patient-centric facilities that offer extraordinary care to patients, and their growth has been stunted in Connecticut because of the surgery center tax. So we are seeking to repeal that tax in Connecticut or do anything to ameliorate its negative effects.
We have a few questions in the chat area, so I'm going to ask them in the order they came in. The first question is from Lisa Klein of the Hartford Business Journal, asking, does CSMS have a position on Comptroller Lembo's proposal for a public option health plan?
We've been communicating both with Commissioner Lembo and others about the plan. Unfortunately, the details aren't out there that we can give a comprehensive opinion, because the devil is going to be in those details. Right now, if the plan is as stated, where physicians are going to be reimbursed for their time, then as the same rates that they are there now, then this is something that we can support. But we're very concerned that the public option plan already runs at a loss, and the question is, where are they going to make up that money? And if the rates of reimbursement decrease down to Medicare or Medicaid, that can cause a significant burden on physicians, or they can end up narrowing networks so that they can control costs, and then people will not have access to healthcare. And to go back to my first statement, which is we want to support plans that provide patients with access to high quality, safe care. And so a lot of those details haven't been released. And until we see them, it's hard for us to give a true support or oppose. And so we just anxiously want to be part of the conversation and discussion on where this is going.
We have a question from Eric Bednar of the Journal Inquirer. Eric is asking, what are the public health concerns related to recreational cannabis, and how does CSMS believe they should be addressed?
The number one concern is access to marijuana of the youth, and then the effects that is going to have on youth with mental health and other substance use. We are struggling as a society to address the opiate epidemic, to increase access to recreational marijuana, as we're fighting with tobacco and heroin and fentanyl and other opiates. Just shows how some substances can be very destructive. Additionally, the studies have shown in Colorado, which has had marijuana since 2013, that the youth access has created schizophrenia and much more mental health problems. And that's probably our number one concern. The second concern is the driving impaired. Right now, we do not have a quantitative way to measure marijuana intoxication, but the studies from Colorado are rather clear regarding the effects on the traumas. And just to give you a few statistics, in the first year that marijuana was there was a doubling in marijuana-associated fatalities. And since recreational marijuana has been legalized in Colorado, there's been an increase of 135%. This is going from 2013 to 2019 of drivers testing positive when associated with traffic deaths. So we have seen the impact on Colorado, and we're very concerned about that impact here in Connecticut.
I was wondering, Dr. Shangold, you were talking about, when you were talking about high deductible plans and surprise billing, you had mentioned, you know, people fighting with about essential care and what's covered as an essential claim. I was wondering how physicians are handling this. I know that they've been fighting on behalf of their physicians a lot, or their patients rather, over the years. And I was wondering if that has changed over the years. Has it become more difficult to get essential claims covered for your patients?
So just to unwrap that, more and more time is required of the physician and the physician's offices to interact with insurance companies. What I mean by sort of essential care is if there are some expenses which are pre-deductible. For instance, if you're 50 years and older and you want to get colonoscopy screening, many insurance plans will cover that, and that does not attach to your deductible. However, say your father died of colon cancer and you're high risk, and the recommendation is to get a colonoscopy at the age of 40. That, by many plans, no longer is covered as a pre-deductible expense. And if you have a $5,000 deductible, you might all of a sudden need $5,000 out of pocket. So physicians try to work with patients, but again, if you fund your HSA, the health savings account, and in January there's no money in there and it takes you all year to put money in, many people say, all right, if I need that colonoscopy, I'll just wait till December, and 8 months go by, you know, before that gets completed. Now, physicians will then try to have higher level appeals at the insurance industry. And again, these are all costs to a small business to, on behalf of those patients. And then after the fact, they have to interact, even if a patient does elect to have those services, many times the patient doesn't have the money because they're using all their money to pay these higher and higher premiums. And now that interaction with the physician's office, if they owe them some money, they might say, you know what, I can't go back for 3 months because I owe this doctor money. And they put off what could have been treated, say, early, than something that is much more advanced and costly when they finally do present.
On the question of doctors participating in the vaccination program, is that something that you would like to see pick up going forward? Is it too late to change that?
No, it is something we'd like to see going forward, because the unanswered question about those patients that have immune deficiencies and other things has not been answered by this age system that's out there. One of the problems is there are people in their 20s and 30s with renal failure, and they have to wait to get this injection. It would be much better if there was a way of moving them up into the line. I understand the complexity of doing that, but it would not be complex if it was within a doctor's office, where the doctor could make a decision that this is an immune problem for this patient who would do better with the vaccine than somebody that's 45 and running 10 miles a day.
And I think originally with the Pfizer and having to be stored at such low temperatures,
Right.
and how short the short life was once you defrost it. A doctor's office may have been a little bit more difficult, but certainly like the single shot of Johnson & Johnson seems more amenable to be able to be provided at a physician's office.
What percentage of physicians, primary care physicians, would you say reached out to their patients over 75 for to help them set up appointments or to encourage them to set up appointments? Obviously, it's a large number, but I assume that act would and did fill in for some of the intervention that you were talking about.
Well, I think if you look, still half of the physicians are still in quotes in private practice. The other half are attached to the bigger systems like Hartford Health or Yale or
Right.
Nuance or some of the other ones. Those systems, the larger systems, reach out through the internet and their portals, predominantly what's called MyChart or MyChart Plus. That's how they reach their patients. Our other private practicing physicians reach out through their offices. Most of them put out a blurb or something to the patient saying, call us if you're having difficulty. And it's handled at the front desk level to help people go out and get the information. That works for what Greg was saying. That works for the people that want the shot. The problem we're having are the people that are hesitant to get the shot. We need to move them into the system and figure out a way to convince them that the shot is extremely important.
And I think you recently probably observed the whole removal of the religious exemption for vaccines. And I think for many of the people that have this vaccine hesitancy, the COVID vaccine is not any different than measles, influenza, pertussis, tetanus, people, all the other vaccines that we have out there that really are some of the best. I mean, they're almost the treatments, but they're really the preventions of many bad diseases. I mean, having seen kids really at the beginning of my career with epiglottitis, and now that disease doesn't exist because of the vaccines that we have, is truly amazing. But some communities do not have enough penetrance, and watching that the public testimony shows you that there's still that concern in the state. But for wherever the physician can come in to provide their reassurance and try to improve people from getting vaccines, we want to be part of that.
And we have to recognize that we're in a very critical phase of the pandemic right now, where the inroads made by vaccination, as helpful as they are, may be leading to complacency.
Yeah.
And if we really don't pursue this aggressively every way we can, especially directed from the medical home, we're going to be in trouble.
If you don't mind me just throwing in the question, I know that part of the legislative agenda, you guys had mentioned codifying some of the physician protections that were outlined in the COVID-19 executive orders. And I was wondering, I think I know what you're talking about, but if someone could expand a little more specifically on what you mean by that.
So I believe it was Executive Order 7U and then Executive Order 7V that put in some COVID protections. Certainly at the beginning of the pandemic, while the system was really being stressed out, decisions were made based on the resources that were available. Who got admitted, who went home. The treatments weren't clear at the time either. And so during that sort of, I mean, people have used the word of that sort of haze of war, because that's what it really was at the beginning. There was protection to the physicians. Connecticut is already, Bob had mentioned that many young physicians don't choose Connecticut. One of the reasons is we have one of the worst med mal reputations, and it hasn't been discussed in a long time, but certainly when these decisions were being made about specifically COVID patients, but it had to do with all patients. It was, you couldn't do a stress test on someone you normally did because they had to be COVID screened. And so we were making decisions on a lot of different patients. And we just feel that protection should be in place while there's still a state of emergency in Connecticut. Now, overall, are there things that could be done for Med-Mal. We believe it's a discussion to have. Other states have done this, that have attracted physicians and actually improved access to care. So again, access to high quality care is important to have that workforce. We already see doctors that try to not take call in emergency departments because of Med-Mal reasons. And and I think there's a lot of things that can be done, and we think it's time to have another conversation. It's been over 10 years since the last time and anything was passed addressing the Med-Mal situation.
I want to thank you all for joining today, and I'm going to throw it back over to Bob Russo to close us out.
Yes, again, thank you very much for listening to our concerns about the patients and the physicians in the state. It's important that we interface and you get an opinion from our side of these issues. It's important for public health, health equity, and other entities that are out there right now. We really need to band together to do it the right way. So thanks for your time today, and we're available. Thank you.
Thank you all for listening to our conversation on the Connecticut State Medical Society podcast. Please use the contact information provided here for questions and more information related to the legislative activities in the 2021 session. You can listen to other episodes of On Call with Connecticut Physicians at the Connecticut State Medical Society's website, csms.org. Be sure to engage with CSMS by following us on Facebook, Twitter, and LinkedIn. We look forward to seeing you here next time.